welcome to our Canadian Veterinary Medical Association Town Hall series. I'm Dr. Enid Stiles, current president of the CVMA, and it is my absolute pleasure today to have another, my first of my presidency, Town Hall series with Dr. Scott Weiss. It has been generously sponsored by Hills. And I know we took a little break the past few months. Hopefully everybody had a wonderful rest of their summer and have taken some time to re-energize and get ready for our next fall full of lots of good things, including, I guess, some more COVID. So I'll pass this on to Scott, but just to remind you, you should all be already placed on mute. If not, please make sure to do so. We will also be recording this webinar, and you can access that on our website. Usually in about a week, we'll have that available. And certainly, if you have any questions at all during the webinar, you can press down at the bottom of your screen. You should see a little chat box, and you can write your questions in there. We'll be taking a look at those and try and get to as many as we possibly can. If there are any that we don't get to, we'll certainly try and write them down and get back to you with some pertinent answers if we can. So on that note, let's take it over. Thank you very much, Dr. Weiss, for joining us today.
Great, thanks a lot. Get some slides brought up here. So thanks everyone for joining in. There we go. We should be good now. So when we start talking about restarting these in the fall, like one of the thoughts is, what do we talk about? And then as I started to put stuff together, it's like, holy crap, I got a lot to talk about. So I'm going to focus on a couple different areas. One really is going to be on the human side. We have to understand what's going on with COVID in people to understand how to effectively reduce risk and maintain practice. So I'm going to talk about what's going on and how you can assess what's going on in your area to help you make decisions. I'll hit on the animal side. Not a lot has changed in the animal side, although I'll give you a bit of a heads up for some things that are coming out tomorrow. And then we'll get back into some of the examples of practice issues that we've largely talked about before. And any comments, questions as we go through are good, especially at the end when we start talking about some practical issues. So where do we stand with human cases? Well, I would say across the country, not great. It's different in different regions, but in general, we are seeing the second wave that we expected to see in the fall. It certainly is coming through, and there are some pretty concerning signals over the last week or two. I think we have to start thinking about what kind of restrictions we're going to run into. And like we said before, this isn't, we weren't trying to blunt the wave, we were trying to blunt the series of waves, because we're going to continue to have problems. So part of it's understanding what's going on in your area. So you can figure out what risks and benefits we need to balance. So you've seen this epidemiologically, right? I'm not going to talk too much on the epi side, but when we're thinking about this virus and the data that you can see, we need to think about a couple different numbers. So one is RT. That gets mentioned a lot. A lot more epidemiology has been learned by the general public in the last 6 months than ever before. So RT or R naught. So R naught is the transmission rate of the bug. So that means that how many people does your average infected person infect in the normal state? So the R naught for this virus is around 2.4 or so. So that means that every person that's infected usually infects about 2 point something people in the normal situation when we're not trying to control anything. RT is what it really is. So, we should be doing things to drop RT down. And we want, so even though average person could infect 2.4 people, because we bring in measures, we drop that down, hopefully. And if it becomes less than 1, the outbreak dies down. If it stays over 1, the outbreak ramps up. So knowing the RT status lets us know which way we're trending. New case rate, obviously case numbers are important just to know how many are there and to put some of this into context. Your RT is very volatile if you have a low case numbers, because that one person infected a few people can really skew things. So you need to understand how many cases are happening. Test numbers are really important, because if test numbers go down, we're missing things. So if your case numbers are going up and your test numbers are going down, that's bad. If we have a lot of tests and our case numbers are low, that's good. And that ties into test positivity rate. So if we look at our tests, you can say that, okay, 0.01% of tests are positive. Well, most people that are getting, we're more likely to test people that are higher risk. So if our rate of positivity in that group is really low, we're probably not missing a lot in the general population. And it's thought that over the summer, with our case numbers being relatively low and testing relatively high, we were capturing the vast majority of positive people. as your test positivity rate goes up, like if you get into 5 or 10% of the people that are positive when they're being tested, that would suggest there's a lot more out there. There are more cases that we don't know about. So looking at these things is really important to figure out what's going on in your province. So for me, concerning indicators are no information, right? If we don't know what's going on, that's a problem. High RT, again, being aware if we have low case numbers that can go up and down all over the place, but an increasing RT is an issue. High new case rate, high new hospitalization rate, high test positivity, low test numbers, or low test numbers in the face of increasing everything else is a big concern. Now, we're really worried about hospitalization and we're really worried about deaths, but we can't focus on those to control what we do because there's a big lag. Like this isn't like influenza where you get exposed and you get sick and you get really sick, or you don't quickly and you get better, or you don't quickly. What happens here is, if I get exposed to this virus, incubation period is around 5 days. So I start to feel like crap after 5 days, and it takes time on average. So I might be feeling rough for a little while, managing at home, and then I go to the doctor, and then maybe I go to the hospital. I spend some time in a ward, and then I get worse, and I go into ICU with more oxygen, and then maybe I go on a ventilator, and then it's a long time. So death is very much a lagging indicator. And even case numbers, so we see changes in groups, those get reflected later on. So because people that are getting affected right now that are going to die may not die for a month or a couple of months, we can't just rely on looking at deaths. We have to pay attention as we're heading into flu season where hospital capacity is going to be an issue. We don't want to add on to that, but we can't say, okay, well, death rates are pretty good right now, so we're pretty good. Because you don't know if things have become a wreck until people start dying later on. So if we look at Ontario, we've got some good data from Ontario. We've got data from other provinces. We've got more Ontario data here. RT has been increasing. We were in good shape back in July. It was well under 1. Things were dying out, and then things increased. Not surprisingly, as restrictions were taken away and as people got kind of sick of doing what they know they're supposed to do. So RT has been well above 1 for the last month and a bit now. And that's why we're seeing the spikes in cases that we're seeing. If you look across the province, this is from Monday. Again, the red and the yellow and the green are based on a couple different metrics that come up with this. This is from Ryan Imgrund. There's really good data on Twitter. Imgrund, if it is IMGRUND, I've got his name on one of the later slides. He publishes this stuff every day. He's a biostatistician and a high school science teacher, and he's really taken the lead on some of this data collection and reporting. So you can see RT is above 1 in most areas. Some places the case numbers are really low, and you can see there's a big confidence interval such as PEI. But we are seeing some concerning indicators in various areas. In Ontario, we kind of get this at the health unit level. And you see some places, Windsor, Essex, Peel, and Toronto are high risk in terms of hospitalization, in terms of case numbers, in terms of RT. So putting all these things together can be useful. And I think this column is really interesting for me, I think, from a practice standpoint. And what this is saying, based on those numbers, it's assuming they're homogeneously distributed, but based on those numbers, if you are in Windsor, Essex, and you encounter 182 people, you got a 50-50 chance one of them is infected. Now we start thinking about it in the context of a veterinary clinic. How many people come through your clinic every day, to your clinic, or ultimately through your clinic every day? We start thinking about that risk is. That risk might be very low. In Hastings, it's over 5,000. As things go up, it drops down really low. If you look at some of the places in the US when rates have been really high, it's been under 100. So not hard to see on a every couple of days basis, there might be someone coming into the clinic. Now, this isn't the most accurate thing because people are sick and they're isolating and everything like that, but it just shows that the more is out there in the community, the more we could plausibly see these come in. And as you know, one of the concerning things has been the age shift that's happened. Now, the age shift to younger people is good from a death standpoint because younger people don't tend to get seriously ill. They can. Kids can die of this. It's very rare. But over the last few weeks, the case numbers have come up a lot in the young population, the 20s. Part of that's fatigue with restrictions, part of that's university, partying, and everything like that. And here's where the time lag comes in. So what happens after you get a big cluster in your 20s? Well, you get a big cluster in your 40s and 50s because their parents get infected. And then you get a cluster in the 70s and 80s because the grandparents get infected. So the younger individuals may not drive a lot of disease and a lot of hospitalization themselves, but they can result in that. And that's a group we certainly have to worry about. When you think about people in your clinic, it's not enforcing, but kind of develop responsible behavior is really important. And that test positivity thing that I'd mentioned before, test positivity rates back at the start were high because there wasn't much testing done. Testing was focused on sick people. So you can see where most, a higher rate if you're just focusing on people that have been exposed and they've got respiratory disease. As more widespread testing came in, test positivity rates were very low, often under 1 for sustained periods of time. And now they've shot up from that 1 for less than 1 for all age groups. If we look at our 10 to 19 or 20 to 29, that's a pretty high test positivity rate. And again, the higher that goes, it would suggest that we're probably missing a lot of people that are infected and that are positive. And there's some other ways they're being looked at. So an example, there's been concern around London with Western University. There's a small outbreak there. Now, is the small outbreak really a small outbreak, or is it one that's not really identified? Because testing has been limited. The number of people they can test in the university has been small with long lines and not getting everyone done. And they've also found positive wastewater results. So wastewater testing is done to look at sewage, right? I mean, once you hit a threshold where there's enough virus in the community and nothing that makes it into sewage. And there are positive wastewater results from what I've heard in London. That means there are enough people shedding this virus that you get a detectable amount in sewage. So there's probably a big uncaptured population of people with this virus there. So we're seeing indicators in various areas that are quite plausibly going to lead to more restrictions or lead us to think, okay, maybe we need to look at our own practices. I just put this up there. If you know what's going on internationally, it's a big mixed bag. There are some countries where have really high rates. Some countries have had things under well control and there are a big second wave. Some have very poor data. Some are doing a lot of testing. So no one's doing exceptionally well right now. New Zealand's been one of the hallmarks as being a small island country. Now, one of the things, this is again, I think this is relevant to us as well, is this is a bit of a weird virus. So I talked about R0. R0 for this virus is about 2 point something. The problem is it's not typical for the R0 distribution. So if you look at influenza, the R0 is about 2, which means most people infect 2 people. And if you do a curve, it's pretty much a curve right around 2, nice little bell curve, tight bell curve. This one is a virus that behaves a lot like MERS, Middle East Respiratory Syndrome, which is very poorly transmissible. Most people with MERS get it from really close contacts, prolonged contacts, or they get it from camels, the original source. So it acts as a very poorly transmissible virus, but then sometimes acts like measles, which is highly transmissible for no reason. And this is a good example. This is a church outbreak in Ohio, I think it was Ohio County, and one person infected, I think it was 57 people. 35 of those infected no one else. Most of the ones that infected someone else only infected 1, maybe 2 people, and mainly within their household. So mother and father, brother and sister. But this guy infected 50-some individuals. So we get these super shedders, and that's a big concern because if you get a super shedder in your clinic, that's a super problem. So most people with this infection don't actually infect anyone else, but some infect a lot. And some of that's biological. Some people that are infected will shed a lot more virus when they're talking than someone else would when they're sneezing or coughing. And then there are behavioral aspects, so crowded spaces, things I'm going to talk about in a bit. But we don't really understand why, and you don't know who the super shedder is until they've super shed. So if you have a staff member that's a super shedder, and you're not doing very good precautions in your clinic, you're going to get it. High chance you're going to have multiple people affected. Now, our understanding of transmission has evolved a bit over the last 6 months or so. So this is still something we focus on as a droplet transmission, direct contact. Aerosol I'm going to come back to. So droplets mean, if I'm infected with this, I'm producing droplets and small particles, liquid particles, and they don't travel very far. And that's why we talk about this 6-foot distance. Some of these particles can be fairly small and go a little bit farther, but most of them stay fairly close to me. And that's what we're mainly worried about. Aerosols I'll come back to, that's a little bit more transmission. Fomites and surfaces, we're really getting less and less concerned about it. And, my flippant response is I don't really give a crap about surfaces when it comes to this virus. There's a lot of disinfection that's done for show. I'm not saying fomites aren't relevant. I'm just saying they're much, much less relevant than droplets. This virus doesn't like to live in the environment, doesn't live very long. We don't have good data that would suggest the environment's a big source of infection. So I'm not saying don't disinfect. And I think we want to disinfect common contact surfaces, human contact surfaces, but I wouldn't focus on that. And what we really run into problems with is people saying, well, what's their control program? Well, their control program is disinfection, right? I'll park you on a plane next to someone for 6 hours. They may or may not wear a mask. You're going to be 6 inches from where they're breathing out beside their mask, but here's a wipe. You can wipe down your seat when you get there. It doesn't help me at all, right? So we need to do some cleaning and disinfection, but we can't do it as a replacement for the stuff that actually works, which is respiratory precautions. So just a question there, are these people super shedding events or are they super shedding people? And that's a great question. That's maybe what I was trying to kind of allude to. There's a biological and there's a behavioral component. And it probably is both of them, because the super shedder requires, you know, the biological reason that they're producing a lot of virus, and they need opportunity to infect a lot of people. Like I would have a hard time being a 57-person super shedder because I don't see that many people, right? We're distancing fairly well, and when I'm out there, I'm masked. So I could be a biologically possible super shedder if I'm pumping out a lot of virus and my family's screwed, right? But I'm not going to have a much broader population. And same thing, I could be a lower level shedder, but if I have a lot of uncontrolled contacts in close spaces, I can maybe become a super shedder. We don't really understand them well, but it reinforces why we need to mask and distance, because some of these people can be that. Some people are more moist and close talkers, yeah. Some people are louder talkers, they talk more. Some might be situational. We just don't really understand, but there is a biological component where some people will produce a lot more virus than others. So I said for surfaces, you know, pay attention to them, just don't focus on them is the only thing. Okay, so the 6 foot, 2 meter barrier, we could talk about a lot. Like it's not magic, right? The virus doesn't all of a sudden explode when it gets 6 feet away from your nose. It's a continuum. So close is riskier than farther. 6 is pick a number. WHO has said 1 meter. I think they're rethinking that. CDC, Public Health Agency Canada said 2 meters. Some places saying, well, it should be more. Well, if you're parked 6 feet and 1 inch from someone, does that mean you're no risk? Absolutely not. It means you're a little bit less risk. And if you look at the picture on the right there, this maybe shows it. So I think I've shown this one before, talking about why we wear masks. We're wearing masks to reduce that deposition of particles that we make. But the other reason I want to show this is you see the particle sizes, right? When I'm talking, coughing, sneezing, whatever, I'm making big droplets and I'm making small droplets. And some of these small guys are going to travel farther. The big ones settle out sooner. The small ones go farther. Some of them may go farther than 6 feet. And, you know, if I'm in a closed space where there's no ventilation, some of those are going to be able to stay suspended a little bit longer and travel a little bit longer. If I've got good ventilation, they get swept away. I can't get a nice cloud that accumulates around me or in my room because these small particles don't stay there. But so there's time component, there's a space component, there's a ventilation component. So we have to remember that 6 feet is useful, but you can't say, okay, well, I'm going to be in a room with someone, and you know, if they stay in the back corner of the exam room and I'm in the other back corner, we're 7 or 8 feet away, we're good. Well, I would say you're probably not, especially in an exam room, because of the things I'll come back to in a minute. I'm just going to put this up there. There's a lot of study being done on airborne transmission. A lot of it's pretty bad, where, you know, mannequins spewing out things that don't look good but don't tell you a lot. But basically, if you look at places where transmission is looked at really well, especially healthcare facilities, if you're doing good precautions and you're keeping distancing and wearing masks, risk of transmission can be really low. What we do works. And especially in healthcare, human healthcare, has been shown really well. This is from an infectious disease physician, his comment that, you know, most people that got infected in hospitals, most healthcare workers that got infected in hospitals, got it from each other probably, not patients. And it's been shown in some studies where people working on COVID wards didn't have higher COVID acquisition rates than people not working in COVID wards or people without clinical care, because they weren't getting it from their patients because PPE works. They were getting it because they hung out in offices and meeting rooms and lunchrooms and nursing stations, and they took their masks off. So what we do as routine prevention works when we do it. And that's easy to forget in the clinic. You're there all day, you're working with this bubble, your group, and that's when we run into risk situations. So we talk about the 3 C's a lot. This follows up on things I was talking about before. So closed spaces with poor ventilation, crowded places, and close contact settings. And then I added a 4th, which is continuous, so the 4 C's. You know, this defines a veterinary clinic. This defines an exam room, absolutely. Small room, poor ventilation, multiple people in there. So you've got, you know, a vet, maybe a tech, maybe an owner, maybe a couple owners. We're in this really small footprint that doesn't have great ventilation, and we're talking. That is the perfect situation for transmission of a respiratory virus. So that's what we need to think about when we talk about, you know, if and when people are coming back into the clinics, how do we reduce the 3 C's or the 4 C's, right? Shortening time is another issue. You can get away with things by having short durations. And you can get away with things by improving your PPE. You know, not completely, but you know, 1 minute in a crowded space is different than 15 minutes in a crowded space. Wearing a mask is much different than not wearing a mask. So we can do some other things. This is from the US. The US has obviously had some big disasters when it comes to group situations. Universities are a big problem. The US has had a lot more COVID in clinics too. A lot of clinics that have had problems with COVID. We've had some in Ontario for sure, and I've heard of a couple outside of Ontario, but we hear most of it from the US just because there's more disease out there. So I'm happy to come back to any of this stuff after, but I really want to set the scene for thinking about what kind of practices we do and what creates risk. And you know, one thing we need to do as we go through this pandemic is reset periodically, saying, okay, what do we know now? What were we doing before that really doesn't make a lot of sense or we don't need to do? Like I was concerned a lot more about the animals of fomite in March because we didn't know anything about this. And we know that fomite is concerned with some respiratory viruses. Now I'm much, much less concerned about that because we just don't have good evidence. I'm not saying don't think about it, but I'm saying I think hand hygiene, routine practices, as opposed to thinking about biocides on high-risk animals. Or routine biocide use probably makes more sense. We do need to reset periodically and think about what we know and what we can do. Not a lot has changed on the animal front on the dog-cat side. There's been a little bit, and there's been some more on the food animal side. So just to recap, so dogs are poorly susceptible to this virus. They can get infected. It's not convincing they get sick. So experimentally or in field studies, they can get this virus. They can shed the virus, probably not much, probably for a short period of time if they do. The hope is most dogs that get infected and get a subclinical infection and aren't shedding the virus and are dead end hosts. And I think that's a reasonable assumption for dogs. We can't be completely confident in that yet, but dogs are pretty low risk. The owner obviously is much, much greater risk to someone than the dog. If we look at data from the US, the dog and cat numbers are pretty similar. USDA puts this up. It's about a little over a dozen of each. Not a lot of testing has been done. So all we can say is, yeah, dogs can get infected. Yeah, cats can get infected. Do dogs get sick? There's still controversy. There have been a couple sick dogs, but are these dogs that have COVID or are they sick dogs that happen to be infected with this virus at the same time? Cats more convincingly get sick. So cats are relatively susceptible to this virus. They can get respiratory disease. They can get GI disease. We don't know how often they get sick after exposure or how often they get seriously ill. I suspect it's got a similar continuum that we have with people. Most infected cats don't get sick. Most ones that get sick get mild disease. Some get more serious disease. And that's the serious disease is mainly from the anecdotal side. They can infect other cats. So can they affect people? Probably, right? Realistically, if a cat can infect another cat through respiratory secretions, if we mimic those behaviors, we stick that cat's face in our face or sneezing at us, then there's probably some degree of risk. What's the big picture risk? Pretty minimal if we use common sense, right? If my cat is infected, it got it from me or someone in my family, and they're going to be a greater risk than my cat. My cat's a byproduct of the infection. Where it becomes a concern is if my cat gets it. And so we're worried about cats maybe being a bridge. And I think the risk is still pretty low, but if I infect my cat and my cat goes outside and infects a litter of community cats or a colony of community cats or the neighbor's cat, then we can maybe see it bridging. The other place we might see cats as a bridge is vet clinics, right? Veterinarians and shelters where we aren't exposed to the people in the household. If we do things right, we're exposed to the animal. So I think we still have to consider cats a potential zoonotic risk, especially if they're sick. But the risk is probably quite low. It's gonna be very difficult to confirm whether we get cat to human transmission. But I think there's enough evidence there that it's still a plausible risk. How common do we see it go human to pet? We don't really know. So if you look at the surveillance, I've mentioned the surveillance studies that we've been working on. It's been really slow going. But for the PCR-based surveillance, so looking for shedding the virus, we identify households that have COVID and people, we have to get in there at that same time that they're sick and sample their animals because they're only going to infect their animals over a fairly defined period of time. And you know, cats only shed for 3, 5, 6 days based on some experimental work. And dogs may not shed much at all. So we know we very much underestimate it. And serological testing will tell us a lot more. So looking for antibodies because it doesn't takes out that time component. And it makes it easier to get samples. So if we look at some studies, there's a study in Wuhan, I think I mentioned before, 14.7% of cats were antibody positive against this virus. And these were mainly what they called stray cats. Now the question was, were they really stray cats or were they cats that were indoor outdoor cats from COVID households, or cats from people with COVID that released them because they were sick or they were paranoid or because they died? And we don't know. What it tells us is the cats can be infected and we can get a serologic response, and it's not that uncommon. A study from Italy, these weren't known positive contacts, but 3.4, 3.9% of cats in an endemic area. We have some data that are going to be released tomorrow as part of a European conference that will probably get a bit of attention. Part of it's our PCR data, where we had only one positive out of about 40 animals. So one non-negative. It was a inconclusive. It was a positive and negative and a weak positive. And what we suspect is we got the waning end of the infection, so we didn't get a true positive. And we've started serological testing. We have a couple different serological studies going on, try to define how much transmission we've had, looking at a few different groups. We're still in search of animals of exposed households or infected households, but we've got, it was only about 10 cats, with 10 cats and 8 dogs, about 50% of the cats and 20% of the dogs from COVID positive households were seropositive. And the cats that were seropositive were cats that had been sick. So there was COVID in the people, the cats had respiratory disease around the same time, cats now have antibodies. So these cats probably had COVID, probably a mild case of COVID. Does it freak me out? No, like I think we suspect it. Like I've been saying all along, I'm trying to say it too loud in the public, I suspect there are thousands upon thousands of infected animals out there. Just because we're infected and we have close contact with them doesn't mean they're infecting us. It doesn't mean there's a huge animal health risk, but it means it's something we need to pay attention to still. So reinforces the fact that human to animal transmission is probably not uncommon. Severe disease is probably uncommon. The risk to people is probably low, but we still should take some precautions because I think there still is a plausible risk. Just gonna pause, I think there's another question or two there. How long symptomatic care can pass on the virus to others? So if we're talking about people, it's a pretty short period of time. Now, if we look at PCR, there's a well-understood, well-known phenomenon now. Sometimes called long haulers, people that have prolonged PCR positive results for weeks, even months after initial infection. I don't think anyone's ever been able to isolate viable virus from someone after 10 days. So we see prolonged PCR positivity, but there's not evidence that those people are infectious, which is why if you look at most of the guidance from different countries have different guidance, but the general approach is if you're positive, so you isolate until 10 days after the onset of symptoms or onset of your positive test if you're asymptomatic, as long as you've been asymptomatic for the last 24 hours or 72 hours, depending on the guideline. But there's a very defined time period, about 10 days, wherein that risk of shedding seems to be the highest. So we don't tend to have long-term carriage in people, or we don't have long-term like infectious carriage in people. Cats in experimental studies has been more in the 3 to 5 day range. Dogs would be even lower. So it's not that long of an infection, which is good. The information on how quickly they develop antibodies to the virus, not really. Our numbers are still pretty low. One of the things we run into is we think that they probably lose neutralizing. It depends on the test that gets used too. So we found you can look for neutralizing antibodies, which has been one of the standard approaches. And it looks like those disappear relatively quickly. And if we look at IgG, we'll get positives. So we have seen kind of the classical, they got IgG and they got IgM. Whether that takes days or weeks, it's hard to say. Like could we test them too early? Possibly. But we'll maybe find a bit more in some of our surveillance. Mink, interesting. I've talked about mink before. Mink are a big problem in the Netherlands and Denmark. Denmark's the biggest mink producing country, and they've got a few infected farms. The Netherlands is more aggressive. They've got over 50 farms now that are positive. And mink being infected wasn't really a surprise because they're closely related to ferrets, and ferrets were nicely susceptible to the first SARS and experimentally to this SARS virus. Where the concern has been just how easy it is to affect the number of farms that have been infected in a country that's not exactly rampant in terms of COVID in people. But these 50 farms, you got transmission from human to people, or sorry, human to mink, and then there's been mink to mink transmission. And there's also been mink to cat transmission. They've sampled some feral cats on these farms. And I suspect that's from manure because they're not hanging out with the cat. And there's also been mink to human transmission in a couple situations. So we are seeing an animal species acting as a reservoir for infection of both another animal species and humans, which is our big concern. We don't want animals involved in the epidemiology of this. We don't want to have to worry about stray animals, wildlife, or anything like that. The risks are probably low, but that's why we're really emphasizing keep infected people away from animals, especially wild species. and groups that might be a big enough population. So if you look at field research for wildlife, bats in particular, really been curtailed because we don't want people going into bat caves in case they might be shedding the virus. We don't know that our native bats are susceptible, but we don't want to find out by infecting. Okay, livestock really quickly. There's been some press lately. There are a couple studies involving some Canadian research from the federal government and some other species or other groups. Basically, the take home is, depends on how you spill it, pigs are susceptible, but not very susceptible. Experimentally, they could be infected, but not very often, not sick, very low grade infection, ability to see antibodies and find virus if you look hard enough in certain tissues, but not really a susceptible species. I still don't want someone with COVID going anywhere near a pig farm because I don't want to see the odd one breaking through, but it seems like livestock are limited risk. Cattle, fairly similar. Some degree of susceptibility, very low susceptibility overall. Poultry, it's a non-issue. Horses, we don't know. We're guessing they're not very susceptible based on some, looking at the receptor, it's probably not very susceptible. So livestock are less of a concern now than they were at the start. Pigs were our big concern at the start because based on some predictive modeling, they should be susceptible and they're just not very, which is good, but I'm not saying they're not. Excuse me. I think there's some Q&A box questions. I'll check on them just as we pause here. So were animals assessed with the same ELISA method? Is that the same method as per people? If it's the same method as people, no. They're different tests for different species because they are species-specific tests. We have looked at a multi-species test that's used on people. It does not perform well on animals right now, the one that we've been looking at. Part of that might be it's looking at neutralizing antibodies, which might disappear fairly quickly. But there's still a lot of work being done to sort out proper serological testing. Different antibody tests for people have very different sensitivity and specificity, absolutely. Also, were the decision thresholds that the different research groups use the same? Well, there aren't that many groups looking at it. No, there's not a standard approach to it. You know, and it's based on kind of typical ELISA development. If you look at our serological stuff, yeah, there's always some sensitivity to antibody tests. We look at our data, you know, they make sense epidemiologically, they dilute down properly. If we look at animals that were negative, so pre-COVID samples are all negative, so we don't have specificity issues. But still, antibodies, you know, you're looking at a target you can't correctly look at like something that you grow. So I think there's always some degree of a grain of salt with serological data, but that's probably, you know, was 14% really, you know, 11% or 18%, not was it 0% or 14% or 100. It probably is more, is how refined is that versus a yes, no. Is a face shield enough for a vet to wear? If you add some fabric at the bottom to make it longer, I would say no. Like face shields do something different, right? Masks protect others from you. Face shields protect you. Face shields cover your eyes. That's what they do a good job at. They don't do a good job protecting from your respiratory secretions because things can move out around very easily. If you added fabric to the bottom, maybe. Airflow is still going to be directed around the fabric, probably not through the fabric. So if it's being directed around the fabric, you're still getting unfiltered air out. Now that might flow behind you, which might be fine in the situation, but you know, I'm not sure. I think if you put enough fabric around a face shield to actually give you good protection, it's probably going to be more uncomfortable than a mask. I think it would heat up a lot quicker and fog up a lot quicker. So generally, so there's a lot more talk about face shields as an alternative to masks at the start, and really everything's coming down to masks being the thing. Face shields are an added tool if you want an extra level of protection for yourself or for high risk situations. Face shields are not a replica for masks. I think you'll see it, and I think we've seen that with schools, we've seen that with workplaces, where most of them are very specific that it's a face, it's a mask, and it's not a gator. It's a real mask. It's not a bandana you pull over your nose. And there's more and more evidence showing that, you know, properly non-medical masks that are properly fit and properly sized and of reasonable quality are highly effective. Face shields are less predictable. Face shields also, you tend to see people wearing them up kind of like you do OHL hockey player, junior hockey player visors, right? They're a face shield that's up around their nose or over their eyes, so they're not actually doing anything. There are some situations, and this is where you get into people with hearing, dealing with deaf people, or people with hearing problems, where they need to see the lips move, and that might be something where you make a transient exception, right? So you've got a client that you need them to see your face, and there are some other groups too that just need to be able to read facial expressions. So I think I would be cognizant of that, and I would have a shield you can pull out in that situation, because, doing it once a month or once a week, you're adding risk, but you're adding minimal risk. It's when you start using it as the complete replacement that I get concerned about it. So I would say in general, no, we don't want to use shields as a replacement, even if we, added some things to them, but there might be situations where they make sense. Am I recommending additional air purifiers to rooms? I think I was going to I'll hit on that. Actually, I'm going to leave that one for a minute, because I think I'm going to get into some more ventilation stuff later on. But it's a great topic, because that kind of leads into where I'm going now, is where risk is. And risk is a continuum. So, me in my office by myself, no risk. Me outside with my bubble, very low risk. The more I get closed spaces, the more people I bring outside of my bubble, and the poorer the ventilation, the risk goes up, and you know that. Just a couple more things on masks. I'm not going to spend too much time on masks, because I've spent enough on it. But here's a study, modeling study said the estimated that a person standing 2 meters from someone coughing without a mask was over 100 times more exposure to respiratory droplets than someone standing 5 centimeters away with a basic single layer mask. So a mask that's actually beyond worse than what we would say would be good. We want to talk about 2-layer masks. Masks work is really take home. They're not 100%, but they do a very good job in reducing droplets. And just one more mask thing, I've talked about this before, but the exhalation valve thing is a big issue. We see them very commonly. I'm going to move some things so I can see my screen on the right, but you can see this is N95 on the bottom. I think you can see my arrow. So this is a really crude thing. So I took a homemade non-medical mask, a medical mask, and an N95 mask, and put them on and blew really hard through them onto a culture plate, nothing grew. I took an N95. So this is an N95, proper N95 mask, but as an exhalation valve, did the same thing and got lots of droplets coming out, lots of bacteria, because that's a one-way valve, right? If you're using an N90, if you're using a mask to protect you, a one-way valve on the way out is fine, because you don't care what goes out, you care what comes in. But that's not why we're using masks. And the masks you can see on the right here, sort of move some things around so I can see it. These are still fairly common, and they're doing very little to protect people around them, right? What they're doing is concentrating air through that valve, which, it's directing it one way. So if I'm standing on the other side, maybe I'm in okay shape, but it's probably sending out with more force through that valve. So, a lot of places specifically banned masks with valves, and I would recommend that too. They just aren't doing what masks are supposed to do. Hopefully many have seen this. This is our latest iteration of guidance with OVMA on this is going to be a bit of a monster document. And there's a question about ventilation. If I don't cover it well, we do have some information on ventilation in there too. So this goes through a whole range of areas. And if you see things that we haven't addressed or they're out of date, let me know. We want to keep this moving as best we can. But this goes over a lot of situations and things that we can do to reduce risk. And it has our standard table here, which is our PPE recommendations for different situations, ranging from a mask in that normal interaction up to the highest risk situation, which would be you've got a cat from a COVID positive household, and that cat has a respiratory disease, and you have to be near its face. You have to do an emergency dental, or you have to do an intubation, something like that, where you're in an aerosol generating procedure. That's the one place I think N95s are ideal if we have them. So, I've talked about, we said this is not an airborne virus, right? It's a droplet virus, and the whole droplet to aerosol to airborne is a continuum. So it's not airborne like measles. So if there's someone in the grocery store with measles and they're coughing, and you go in 2 hours later, you still might get measles, because that virus is hanging out, it's wafting around, infecting a lot of people if they're not vaccinated. This virus isn't doing that. But we're worried about those smaller particles of aerosols, where if I'm in a small room and I'm talking away for a while, it just gives more time for those particles to accumulate and stay around a little bit. They're not going to stay there for hours or days, but they concentrate a bit in the air. And if I don't have any airflow to move them, then we start thinking about air. So we still don't really understand the role of the airspace. It still is very short term, very short space, but when you bring in certain circumstances, such as an exam room with long time talking, no ventilation, the airspace becomes more of a concern. So our goal really is to make inside outside as much as we can. We want to improve airflow to disperse those clouds. So there are some guidelines. The last one I heard from the WHO was 8 to 10 liters per person per second airflow. I have no idea really what that means in terms of our building. So talking to your HVAC person makes sense. What we want to do, basically what I want to do is crank it up as much as you can and it still works, right? We have issues in the winter with trying to maintain temperature, but we want to get as much airflow as we can. And doing that through the HVAC is one way. Doing that through in-room methods is another way. Also want to limit recirculation, which obviously becomes an issue too when it's really cold. If you're trying to circulate a lot of air through and not reuse any air, that's going to be a big stress on your system to get it done. But talking to the HVAC person, just trying to figure out how much airflow you can get in your clinic, especially your high-risk areas where people are going to be. Filters, like for me, filters up in the ventilation system don't really help. We're not worried about this virus going up in that ventilation system and coming back down or coming from outside. We're worried about it accumulating in that individual airspace. So HEPA filters in the ducts, UV filters in the ducts, hard to justify. CDC doesn't recommend them. Health Canada, PAC doesn't recommend them. HEPA filters in the room, maybe. So the big thing is, if you've got an exam room, you got crappy airflow, or just, you know, they're inherently higher risk. Bringing in something to move the air isn't a bad idea. If it's got a HEPA filter in it, it can't hurt because it's getting at that air at that local level. So if the HEPA filter's around you, it's going to have a greater chance of sucking things out of that cloud. So one way to improve airflow in rooms is to bring in devices that will move air more. And if they've got a HEPA filter, certainly I'm fine with that. UV systems, like UVC is highly effective for killing things, but it's highly toxic too. Some of these systems are fairly dangerous. There's no indication to have a UV system where, you know, you go out there and you turn it on and leave it for 5 minutes and disinfects everything in the room. It really isn't going to help you all that much. We're not, again, worried about the environment as a big source, and our routine cleaning and disinfection will do it. So we want to move the air more than we want to sterilize the air. If we can, you know, filter stuff out in that short space at the same time, sure, but that's not really a focus. We talked about this before, clinic bubbles. Everyone's talking about bubbles, and the problem is, you know, some people have like 25 bubbles. I mean, it's no longer a bubble, it's a toxic bubble bath. So, you know, you've got your clinic bubble, and you got your relatives bubble, and your friends bubble, and your kids bubble, and the kids' sports team bubble, and all this stuff. And, you know, you've got indirect exposure to thousands of people. So, you know, we try to limit that, realizing that bubbling isn't a way to get away from doing precautions. So I would really caution against saying, okay, we have our clinic bubble, we have 8 staff in the clinic, so we're just gonna be a free-for-all in the clinic in terms of what we do. You know, if you all lived alone, sure, but I don't imagine you do, right? You're encountering other people, so that just brings in risk. So I think we still need to have precautions in the clinic. And I know it gets hard because it's a long time, right? We're talking about this again. We're not gonna be back to normal, you know, this time next year, maybe. Normal-ish. I'm not sure we'll even be there, but we have to figure out how to balance long-term acceptance. So thinking about how we run the clinic and how we change the clinic, like this, again, this isn't a 2-week venture. It makes sense to think about changes and procedures and practices and even physical changes. And, you know, really, the stuff that you're doing now to change things, it's not going to go bad. Like it's going to, a lot of things, if they aren't too cumbersome, you know, they might be good long-term changes, ultimately for efficiency, for healthier staff, reducing cold and flu transmission in the clinic. There are a lot of reasons where this is a good kick to change some things. And it's trying to balance a lot of things. Like we want to be able to function efficiently, economically, you know, still fun and engage and be able to interact with our clients and have that personal bond while protecting everyone at the same time. And often these two are inherently going to be a bit opposed. So the reason I started with this stuff at the start is you're thinking about when, if, and how to bring people into the clinics. You need to think about what your regional risk is, because that'll let you know, what are the odds of someone coming in that's positive. And then you need to balance that with how risk averse you are, how well your clinic is set up to maintain things. Do you have a lot of space? Do you have a lot of exam rooms? Do you have a lot of storage space for curbside drop-off animals, or do you have a small number? Do you have people that are high risk in the clinic? You know, if you've got a 65-year-old type 2 diabetic that's got underlying respiratory disease, that's a high-risk person for dying versus your staff full of 20, 30-somethings that are quite healthy. So we got to put all these things together and start thinking about what we can do. So the regional risk, you know, clinic risk factors are layout, climate, you know, when it's -30 outside, saying go for a walk while we look at your pet doesn't really work all that well. Practicality of all our other approaches, staff comfort, right? Because we still have to be able to enjoy coming to work, and the ability and willingness to enforce the rules. Those are important things for compliance. So a lot of it's just general concepts, right? What are we trying to do? We're trying to reduce interactions, closeness of interactions and numbers of interactions. So we want to limit the number of people that ever set foot in the clinic. And we want to limit the number of people that are in there at the same time. And we want to minimize the time that they're in there. Because we have the same number of people coming to the clinic, but if they spend half the time in there, that drops our risk a lot. We got to limit the time between owners and staff and other owners, because there's that 15 minutes is kind of our exposure window that's usually considered for saying if there's exposure or not. It's not a magical number, but the concept of a quick, hi, how you doing, is a lot lower risk than a 15-minute conversation that we maybe could have done on the phone or through telemedicine. Maximizing the use of barriers, but trying to do that without as much impact. So, I've done some walkthroughs in clinics, and I think it's easy to come up with some logical plans in most clinics to reduce contacts and reduce number of people and how long they're there. So these are some things we talked about before, and I don't have a ton of time on it. So, a lot of straightforward. Hand sanitizers, requiring masks, providing masks if someone doesn't have one. Thinking about layout. I've got a little bit of that at the end, but thinking about how we move people through. We never want a bottleneck where multiple people are getting to the same spot or where people are waiting. Ideally, everyone in a clinic is there for a reason at that time. And waiting for 20 minutes for your time isn't a good reason to be in the clinic if we can work around it. Now, we can't always, right? But we're trying to minimize any of those bottlenecks, any of those delays. Direction of flow indicators, whether you need them or you just functionally do it in a small clinic is easier. Plexiglass is pretty standard. Limited seating, if there's seats there, people will use them, even if there's a sign. So fewer seats makes it clear, and spread out seating in your waiting area, for example, makes it clear, here's where you go. Distancing of front office staff from others and from each other. Exam rooms, I've talked about this before. For me, exam rooms are client holding rooms, right? They're not exam rooms anymore if we can do it. So best case scenario, I'll sketch this out later on. Client comes in, they say hi at the reception desk, they go into the exam room. Ideally, we've got information before, maybe we've done a telemedicine call, this is a follow-up. You come in, open the door, hi, how you doing? Grab the animal, back into the treatment room, do your thing, come back, give them the animal, kick them out the side door, right? You've had a couple of contacts, you've had a chance to interact, you've had a chance for them to, ask any questions. We've been able to do that at a distance. So they're in the exam room in the only chair, which is in the far corner, and I'm at the door where there's pretty good ventilation, but I can still talk and we can still get things done. If I have to, I can step inside and shut the door if there's a real reason for that. So we still get that, but we minimize the time that we're together and we minimize any overlaps. You need enough exam rooms for this, which is why we want to do as much as we can without clients in the office. Because if we continue enough curbside, enough telemedicine, it lets us take the clients that are in the office and do this with them. Because most people don't have 50 exam rooms waiting for people to get tossed into. Treatment areas, again, this is just thinking about, again, the hospital, the risk of transmission between healthcare workers was a big deal. So how do we reduce that in a clinic? Personnel, where they live, where they eat, where they stay, where they eat, how they move, how you stock things so you don't have to be going over top of this person that's doing a procedure or sitting at this computer all the time. If someone's doing data entry there, maybe they could do it somewhere else or at home. But do I want to be going there and grabbing something from them every time, like 50 times a day? So looking at just general layout things. Ideally they flow through in one direction. It's not always possible, but if they can come in the main door, go to the exam room, go out the side door, people are getting more sensitive about this too, right? I think if a lot of your clients now, if you opened up your clinic and they went into your waiting room, and there were 5 people standing around there talking in a fairly close period of space, I bet you would have some that would leave. And if nothing else, I bet you'd have them thinking about what's going on. Some won't care, some will be happy, but there is enough awareness now, obviously, that some people are going to be freaked out by that, and they're not going to like it. So the more we can do for their comfort and mental health, the better. Office rooms, spread things out like that. Lunch space, and again, for me, it's reducing staffing numbers, not reducing what we do, because everyone's swamped. It's amazing how busy most clinics are, but it doesn't mean we need to have everyone in the clinic at the same time. So if we can reduce the number of clinic and the number in specific areas of the clinic, not the number of people working overall, that's the goal. So, spreading out where people are in the clinic, but it's also thinking about, okay, if you've got time, if you get an hour a day, whatever time period, a day or a week, to do follow-up calls and do records or something else, can you block that and do it at home? Right? The more you can do at home, the better. And you look at things like dentistry. Dentistry is a very hands-on profession. They're doing so much more teledentistry and triage. And if they can do it, we can do it. We can't do it all, right? But the more we can do some of those screening things, take management activities, take records activities, take follow-up things, and get them out of the clinic. Or a nice time of year, do it. If you've got a yard outside the clinic or an area, go outside. It's not going to happen for long. But the more we can get people out of the clinic really is the take home. And I'm not going to get telemedicine. There's been a lot in telemedicine. But being creative with telemedicine, using it as much as we can, and considering it for things like discharge, demonstration, stuff that we still spend time, okay, here's your bandage, here's this E-tube, here's how you have to manage it. Well, we may have to do some of that in person, but the more we can do by electronic means, we can shorten that down. And hybrid appointments are really one thing that I think are underused, and we could really have a big benefit there. So, that's saying we need to see the animal in the clinic, but we don't need to see the owner in the clinic. And we don't need the whole time with the animal in the clinic. So the classic is the new puppy, new kitten visit. So that's a telemedicine visit. Let's just talk about nutrition, preventive medicine, behavior. Here's what we're doing with your animal. Do you have any questions? And we can have a nice relaxed chat without masks, like remotely. Okay, so do that on Monday, Tuesday, you're gonna come in and I'm gonna see your animal. So then they do curbside. So all you have to do is bring the animal in, you do your physical exam, you poke it in the butt, you kick it out the door, right? So the client doesn't have to be in the room, but you can still get that interaction. Or if they have to be in there, they're in there for 5 minutes or 10 minutes, not the full appointment time. So again, it lets us decrease either the number of people or the time that they're in there, so we can decrease our density. And I think a lot of people will like that. Some won't, but a lot of people will. And then risk assessment. So curbside drop-off, obviously. Think about everything that we do and what the risk is. Curbside drop-off is low risk, and we can make it quite low risk. Waiting in the reception area gets to be higher risk. Thinking about what we'll accept and what's there at the, what's the cost and the benefit. And we will get to the point probably, and some of you may be doing this now, where you're really case by case. Okay, does this one need telemedicine? Is this one okay for curbside? Is this one we need to see the owner? And it might be because the owner is difficult, or the case is difficult, or their mobility issues, or whatever. And this gets a little bit tough. Like, why am I dropping my dog off at the door and she just walked in with her dog? Well, kind of explain some things, but that's where we need to think about how we, again, try to reduce our numbers and reduce our contacts. Kind of said most of that. I'll hit the questions in a second. We get people out of here. And again, I think just thinking about flow. So look, this is just the thing I picked off the internet, but if you think what happens often, typically an appointment, someone comes in, they go to the reception, they go to the waiting room, they wander around, someone else comes in, we get a lot of mixing there, they go to the exam room, you come in, you see them probably in the waiting room first, go to the exam room, like there's a ton of mixing. We can really make this flow more logical, but they come in, they say hi at reception, they go right to the exam room, we come in, get the animal, go back out, and we kick them out the side door. We bill them remotely, or they go to the front for billing, but there are a lot of ways that we can do. So just stepping back and looking at your clinic can be really useful. So I'm gonna head on some questions now. If there are other questions, feel free to jump in with them. We may end up going overtime on the questions, so don't be afraid to take off too. So what about the use of goggles along with masks? So eye protection certainly will reduce the risk. Most of our transmission is probably inhaled, nose mouth. Our eyes are just two big mucous membranes sitting there waiting for virus. So if you're worried about a situation for protecting our health, so if we've got a situation where we have to have prolonged close contact, adding an eye protection certainly makes sense. For face shield and mask is going to be a little more protection than goggles and mask. Depends on the situation and what you're doing. I think goggles are fine, good goggles, and not just glasses. So when we were, we were particularly paranoid about this, doing our research surveillance. So I was going into households, double glove, Tyvek suit, N95 mask. I was wearing goggles, not a face shield, just because in those situations, a face shield was harder to work with and harder to sample the animal and more likely to get dislodged working with an animal. So I consider you can pick either or. There's some benefits for one or the other. For me, you're getting eye protection, so there's a bit of personal preference that goes along with that. What about the risk of multi-story office buildings with the same ventilation system? And I'm not sure if that means because of common flow, so flow from one building into another. Like, I'm not worried about it going from one room to another or one floor to another in the ductwork. Like, it's not really an airborne virus. So, and that's why I don't think the HEPA filters in the ductwork will really help. So the biggest issue is just the ability to control ventilation. You're going to want maybe a lot more ventilation than someone else might. But I'm not worried about going, if you got a high risk person working in the room next door or the office next door that's disconnected, but you have the same ventilation system, I'm not worried about that. Does ozone kill viruses? Yeah, right concentrations, it'll kill viruses. Ozone, chloride, lots of things will kill viruses. Diet Coke will kill this virus, right? They're not drinking it to protect yourself, but anything in contact with this virus is going to kill it. It's a wussy virus. You can use systems in the air that will kill it. You can use vapor peroxide in rooms and the like, but they're just things that we don't really need. Like if you're looking at a tough spore-forming bug, a resistant virus, that's when you start talking about the systems. We can put them in the exam room, we can hit play and it vaporizes peroxide. or other substances and kills all these hand contacts on these hand contact surfaces is not really something we need here. Let's see, more questions there. And if I'm missing some, jump in, Enid or Laurie. Are you recommending English air purifiers in the exam room? So maybe I've covered that. I think it won't hurt. I think airflow versus purifier, like air movement is what I want. If you get purification with it, sure, why not, right? But I think anything we can do to improve airflow, and that might include, you have something that's moving the air, and you have the door that stays open for the exam room, except when you need to close it. So if you've got an animal that's going to be unrestrained, but ideally, again, the more we take the animals out of the room and take the interactions out of the room, the less important that becomes. If it's in your treatment room, then yeah, we think about where is that positioned, how does it disperse the cloud? So I would still rather have less interaction in the exam room. So if we're going to increase the airflow and keeping the door open will help. What about an elevator when you use that for someone who's not wearing a mask? It's pretty low risk because they're not in there that long. So if someone had been stuck in the elevator for a half hour and you walked in, that'd be a little different story than someone that was in the elevator for 30 seconds, breathing away. The risk, as far as we know, is really low. And I think, it's a common enough virus that we would probably know some of these really targeted things. Like elevators are something that have been looked at a little bit. I think we would probably know if there's a substantial elevator risk from enough investigation. So it doesn't bother me being being in an elevator with someone without a mask. Yeah, that's a concern. It's a short contact, but it's a very small, poorly ventilated space. Coming in after someone just left it wouldn't bother me. People need to be quarantined 14 days when testing positive. The question's moving on me where to go. Is there need to place quarantine in the pets, even though the risk of transmission is minimal, not zero? Yeah, and that's been my line all the way along, is we consider, physical distancing, social distancing, isolation should be kind of family activities. Well, if one person in the household is isolating because they've been exposed, then we don't worry about the rest of the household. If one person in the household is isolating because they have COVID, then the rest of that household should be isolating because they've maybe been infected. And I would apply that to the animal as well, because I don't want me to have COVID, me coughing on my cat and maybe infecting it, then it runs out next door and hangs out with someone else or some other animal. So I think we should be defaulting, like for me, household members are household members, whether they're canine, feline, or human. So if something's gonna be done to the spouse, then we want to do the same type of approach to the animal. And that doesn't mean we don't give them health care. So yeah, it means you've got a household where you've got someone with COVID in the household, you don't need to vaccinate that cat right now. You can wait 2 weeks. If it's got an emergency need for medical care, then we do. And that's when we consider the risk from the person is bringing it. But that's when we would also use a little bit more PPE because the potential of that cat being exposed and infected. What are your thoughts about scent detection dogs? Anybody working on that? I get asked this all the time. Some of the work that's come out so far has been pretty craptastic and it's not been all that useful. There's some groups that seem to have a little more success with it. The problem is picking up, it's not going to pick up a virus because viruses aren't really going to have a smell. It's going to pick up something the body makes in response to that virus probably. Now, is it going to be sensitive? So some of the stuff that's been done has been interesting, but where they've had some success was it took swabs and I think they stuck them under the armpits of infected people, and you'd sit there with the swab into your armpit and then you'd present it to the dog and the dog would say, yeah, that's positive or negative with, okay sensitivity. Doesn't make that much practical use. What I want is a dog that can be sitting at the entrance to the subway and sitting at the entrance to the school. And when someone walks by, they point, you got COVID, off you go, right? That's what we need these dogs for. And that's going to be a tough thing to do. If we're just trying to make dogs a fuzzy PCR machine, I'm not sure how much use that's going to be because they are susceptible species. Not very susceptible, but they are susceptible species. And the bigger risk is the dog's got someone sitting there with them. So if you got a person that's interacting with all these potential suspects, there's some risk. So it's still a really interesting area. If they could ever figure out how to get a dog trained that would be that sensitive that it could be your subway or your bus or your school screener or your university screener, like if we could park dogs at the entrance of every university building, it could actually pick up a majority of people, that would be outstanding. I just don't imagine it's going to happen. How long does the virus survive on the dog's fur and nose? Who knows? Not very long, probably hours max. Like if we look at good surfaces for the virus, up to a couple of days, but that's in really good conditions. And that doesn't mean it's actually viable. So I would think that the real risk, like there's got to be enough virus there to be able to infect you, and it's got to be viable enough for a long enough period of time. So someone with COVID sneezes on their dog and you touch its head and you touch your nose, yeah, that makes sense. There's a risk. 2 hours later, is there any risk? Probably not. I don't know. But that's why we kind of focus on, you know, gloves and hand hygiene and routine things, because we just don't know. But I think the hair code is a pretty limited issue for us. Fabric masks versus surgical masks. It's kind of a broad question, but you know, a mask is a mask to a large degree for what we're trying to do. You know, surgical, non-medical masks can be very similar to surgical masks. They just don't fit a spec. And they're probably as good as most of our, a lot of the non-medical masks that look like surgical masks are basically surgical masks. They're just not called surgical masks or medical masks. So masks really depend on, you know, the weave of the fabric and the number of layers. So the non-medical masks that look like medical masks are probably basically medical masks. The masks that you can buy anywhere, some are pretty bad. I've had to argue with my one daughter who really likes this really flimsy mask that I think is probably doing almost nothing, even though it's her favorite one. So I'm a bad guy because I made her wear a different mask. But I think if we've got a mask that's got, you know, a couple layers or a substantial layer, and you think of that one study, even a mask with just a single layer was quite effective. So I wear a non-medical cloth mask when I'm out. And if I'm talking to someone that's wearing a non-medical cloth mask, I'm perfectly fine with it. I don't like to see a valve mask. That's my only concern. Maybe the last one, using the exam room as a client holding room. Doing the exam and treatment room, how concerned should we be about the safety of the next client? Yeah, that's a great question. I think that's similar to the elevator question. So we don't really know. The difference in the elevator question is there's a bit more risk because they're in there for longer, and there's a bit less risk because there's more airspace and there's airflow. So does it come out as a wash? I don't really know. Should you leave the room empty between? We don't really know. I'd like to see a little bit of time between them. But you know, if the door is open, that helps. If you get good airflow, I don't think there's much risk there. This is where you start thinking about, do we wipe down the hand surfaces in between? Like I said, fomites aren't a big concern. When you start staying in a room and they start touching everything around there, the answer is we don't know. So I'm not, you know, if someone's in there for an exam room and the door has been open and it's 5 minutes for the next person to go in, I think the risk is inconsequential if they've been wearing a mask. No, it's not zero. That's maybe all I can really say, unfortunately, but I don't think it's that big of a deal. But that's why we want to maximize our airflow so we don't have to worry about that as much. Should we make it mandatory to wear a mask while indoors as we're getting into colder weather situations? I think we should be making it mandatory to wear a mask as of like 3 months ago. So yeah, I think if you're around someone, so you know, our policy at the university is unless you're in a place where you know you aren't going to encounter someone, so you're in your own office with the door closed, you wear a mask. If you're walking down the hall, you wear a mask just because you never know who's going to come around the corner. And I think we need to be thinking about that in clinics because you just don't know what the status of the person is, and you don't know that your technician is a super shedder until she's infected everyone. So again, it comes down to risk. It's cost benefit, right? You say, okay, we've got 3 of us in the clinic. I know all of us, we're all really good. And you know, we have kids that are all really good, or we don't have kids, and we're going to accept the risk for not wearing a mask. And we're also going to do all these things to stay as far apart from each other as possible. That's your own choice. Like, you're an adult, right? And clinic management have to be on board with that too, because that means if one person's infected, then everyone else might be considered exposed. And that's another thing to think about when you're thinking about the response. So if your public health response is everyone's exposed is going to be home for 14 days, you want to be able to say, hey, well, no one's exposed, right? We're all in here, but we stay apart, we wear masks. So we're not exposed. And you can make that argument quite well, I think, versus you get that one person in your clinic, okay, well, you're off for 2 weeks. So there are a lot of reasons to think about doing that. If you really don't want to do it, I think you have to just consider the risk you're putting for yourselves and for everyone else and for the clinic. And you have to be really good at everything else. You've got to maximize distancing. You've got to maximize flow. And I think, you realize it depends on where you are in terms of legal requirements too. Because in a lot of places you're gonna have a legal requirement to do it inside anyway. It's not everywhere, but you also have to be aware that they may come in at a point. As cases are starting to ramp up, I think hopefully we're gonna see more mask requirements in places that don't require them now. So you may be forced to do it. So I know I've gone overboard with the question time. So as per usual, I think I'll put the slide up at the end there. If you have any COVID questions or case questions, anytime you're trying to get a hold of me, email is usually the best. Put urgent in the title if you really need to know quickly. Actually, the question, I want to get this last question. The question just came up. You see a value in staff taking temperatures at the start of a shift? No. Temperature is pretty useless for a couple of reasons. It's a very poor indicator of disease. So a lot of people are asymptomatic, so you're not febrile. If you're symptomatic, you may not be febrile. If it's, minus 20 outside and you come inside, you're not going to be febrile on your forehead. You're going to be cold in your forehead. It's a very poor indicator of it. If you have a fever, yeah, I'm concerned. But how many people have a fever that don't feel bad? Like, how often do you really have a true fever and feel perfectly fine? Not very often. So the biggest thing is that culture in the clinic saying, I don't feel well, so I'm staying at home. I don't feel well, I'm taking my temperature and I'm staying at home. I think that's going to be much more effective than saying, we're going to check your temperature on a fairly useless thing when it's minus 20 outside. But I want to keep it a little later, but I think that's a really, really good question. So as usual, I'm sorry, I guess as usual, if there are any questions, let me know. If there's a need for more of these, I'm happy to keep doing them. So it's good to get some feedback of whether we should be doing more of these and what to cover if there are other topics to do. So thanks for putting up with my rambling today.
Thank you, Scott, very much, Dr. Weiss. And again, if you have further questions, you can reach out to Dr. Weiss by email, and you're welcome to also send an email in response to, when you receive the link for this webinar, you can respond to that email. I want to again take this opportunity to say a big thank you to Hills for sponsoring these town hall series. They are absolutely extremely important for all of us to get this information. And of course, what Dr. Weiss managed to give us today was some extremely practical information I think we can take back to our clinics and our homes and use as much as we can. I'd like to just quickly say that we're going to be continuing with this town hall series going forward. We don't know exactly our frequency yet, so just keep up to date with all the emails that we'll be sending with our next town hall series webinars, as well as any Facebook or other social media where you might see that. And also to let you know that we have Animal Health Week coming up in October, and we'll be doing a webinar with Dr. Walter Taves on sort of One Health perspective. It's called Zoonoses and Pandemics, One Health, Eco-Health, and Beyond. We're very excited about seeing that on Monday, the 5th of October from 12 till 1. So again, thank you so much. We'll close off now. And if there's any, again, questions, please feel free to reach us. Thank you again for attending today. And sorry for the issue at the beginning of the meeting.
Thanks, everyone.
Thank you.